And I would like to thank Oculus for planning this session and giving us the opportunity to present our experience on the Pentacam OCT. So we all have known that how we evolve with time, and the diagnostics when it comes to cornea is also evolving. We started from Placido-based topographers, and now then we became Scheimpflug-based topographers. It came biomechanics that, it may help us in planning refractive surgery better. So, and now it's about the OCTs, the epithelial maps, and many more. So we are in a relentless march of evolution of how our diagnostics should evolve with time. So as my previous speakers have also already mentioned, the new Pentacam OCT combines the Scheimpflug technology with the ultra-high resolution corneal OCT technology to assess the corneal diseases and changes more efficiently, which will help us in our clinics for our diagnostic work and the treatment planning both. So as mentioned before, the Pentacam OCT, the resolution of Pentacam OCT being on the more superior side, it helps us to decode layer by layer of how the cornea looks like. I think the time has come that we move beyond looking at the corneal shape or the corneal thickness or just diagnosing our cases based on the slit lamp evaluation. We start looking at OCT and what every layer of the eye or of the cornea, what information it gives us. It also gives us information about the Bowman's layer, the Descemet's layer. In some cases, you are able to even visualize the Dua's layer, and of course, the endothelium. So let's look at some scenarios of how the Pentacam OCT has been fruitful in our clinic. And as we all know that epithelial mapping is very important in refractive surgery and also sometimes in cataract surgery planning, it can impact in the decision-making of whether to choose to do a surgery or not, and also the outcome. Sometimes post-operatively, when you're not able to identify the real cause of an unhappy patient, if you go back and look at the epithelial map, it may give you answers whether it's the epithelium which is causing the problem or it's the patient's refractive error. So this is a case, you can see there's little amount of inferior steepening, but if you look at the biomechanics, the CBI is absolutely normal. TBI and bad D are, of course, suspicious. The TBI is abnormal, but the biomechanics is absolutely normal with a corneal thickness of 530. Now, are we looking at this case which is absolutely normal? Or why the biomechanics is normal, why the thickness is normal, but there's still inferior steepening present. So when we look at the epithelial map, you can see that in the same area where you see the inferior steepening on the topography, you see an irregular steepening of epithelium, a thickened epithelium in that area. If you see this particular area, it's around 46 and 54, but if you go in the inferior zone, it is somewhere between 57 to 56. So there is some amount of inferior epithelium steepening or hyperplasia what you see, which could be masking the topography, the TBI, the bad D. But biomechanics is telling us that probably we should not diagnose this case as a keratoconic eye. Now, what does a thickened epithelium signify? Is it a red flag sign? Can it be overlooked, or should we just evaluate further? So a corneal epithelium, this is how a normal epithelium would look like, but if there is any dry disease or a past history of ocular infection or any ocular injury, the patient has been wearing contact lenses for a very long time, or if the patient is on any eye drops for a longer time, it can affect the corneal epithelium, but not the biomechanics. So can epithelial mapping indicate a deeper pathology? If you see and evaluate, this is from the keratograph, if you evaluate the patient in detail and if you just do a meibography, you can, and a T-bud, you can, a non-invasive breakup time, which is the knee-bud, you can see that there is early changes in the meibomian glands with a little bit of gland loss in the upper lid. And if you look at the non-invasive breakup time, you can see that the tear film is also unhealthy. And this could have impacted the health of epithelium. So what you were seeing on topography needs to be looked at much more detail, and you should solve the puzzle before labeling the patient as keratoconus. And probably if you just go ahead and do a surgery on this kind of a patient, a refractive surgery especially, this patient may have a poor nerve regeneration, a poor optics, or poor quality of vision and glare and halos. So post-operatively, if you get any unhappy patient who comes with a poor quality of vision and glare and halos, it may not be probably the surgery, but probably we should look at the epithelial map, how the epithelial map is, and it would give us the answers of what we should do. Now, as Professor Renato already highlighted, because of the resolution of the OCT, we are not just able to look at the epithelium or the Bowman's membrane or the stroma, descemet or endothelium. Even in the anterior surface, the eye starts from the tear film. We are also able to look at the tear film. And in epithelium, we at times can make out how the epithelium looks like and how the basal cell health is, whether it's healthy or not. And this is how a raw image looks like, and this is how a segmented scan looks like. So because of the resolution, you are also able to look at the epithelial basal cell segmentation, which could help us cornea surgeons in much more detail. So because we are able to see the tear film, the epithelium, the layers of epithelium, and the Bowman's membrane, we wanted to see how the maps what we get are matching with what we are seeing on the OCT. So our team, led by Professor Abhijit Sinha Roy and Dr. Rohit Chetty, they developed this software along with OCULUS, the Narayana Epithelium Evaluation Display, which will soon be integrated, which compares at the conventional and next generation thickness maps with ultra high resolution imaging of OCT. So whenever you do an OCT, it evaluates the corneal epithelium, and it first generates the raw data, what is directly captured from the patient's epithelium. However, what you see on the screen is a processed or smooth data, how the machine iron out the imperfection to create a uniform color-coded maps. This is what you probably see. In normal patients, there's no problem. With a healthy ocular surface, healthy tear film, there's no problem. But if the patient is a chronic contact lens user or any irregular form of cornea like keratoconus, any form of ectasias or post-refractive surgery, any tear film abnormalities, in such cases, subtle irregularities can be lost during smoothing and clinically relevant details may not be captured, was our hypothesis. So how do we go about it? To overcome this, that's why we developed the software. And the software addresses this by preserving the raw image information without artificial smoothing. It starts by highlighting hidden epithelial irregularities that conventional maps might miss. And then it provides a realistic view of the entire epithelium. So let's see how it works. This is how this is an image of a epithelium thickness from a normal cornea. This is how a raw image looks like, and it shows a little bit of variability of epithelium thickness. And this is how a conventional map would look like. When the conventional map kind of smoothens out the epithelial thickness, there is a fitting error, just a little bit of error by 1.31 microns. But with this new software being integrated along with the OCT, it will smoothen out with this error, and it will have an improvement over the conventional maps. In normal corneas, you don't need too much of improvement, but if you see, it doesn't need so much of compensation. But if you see a moderate keratoconus or an advanced keratoconus, you can see that this is what the raw image is. When it created a conventional map, it has a fitting error of almost 2.26 microns, which is increased relative to the normal cornea. And with the new software being integrated, it will minimize this error of 2.26 microns, and it will bring the fitting error as close to 1 micron, which is the normal thing, which will give us a more accurate or patient-specific visualization, a game changer for development of AI or ML diagnostics, which they are already planning. And if you go for even a more advanced case, there is even a more error what you see, and of course, it will be neutralized when this is incorporated. Now, we do know that epithelium, yes, it's very important, but tear film can have an impact on the epithelial maps. So, and you could see on the OCT very clearly that, you can highlight the tear film very well, but you cannot quantify this point of time. So this software will also help us quantify the tear film and optics and show a color-coded representation of the tear film thickness, show how the tear film instability alters the epithelial map, and provide a dynamic view of ocular surface optics relevant to both diagnostics and surgical planning, and it may help in our ocular surface practice as well. The second thing, which we cannot quantify in any commercially available tools at this point of time, is the Bowman's layer thickness. Now, why is Bowman's layer important? Because if the Bowman's layer is healthy, then you don't have to worry. But if the Bowman's layer is irregular or thinned out in any region, then a thinner or an irregular Bowman membrane is an early sign of a keratoconus. This patient is going to have a higher risk of progression in keratoconus, and it also can be an can tell us that probably there is a post-inflammatory status in these eyes. So these changes can have, again, a bearing in how we're going to look at our refractive surgery and cataract surgery planning. So again, with the new software, you'll be able to have a quantification. There will be an overall epithelium with a tear film and epithelium thickness. You'll be able to quantify the tear film thickness, the epithelium thickness, removing the tear film, and the Bowman's layer thickness. And you can clearly make out how the Bowman's layer starts thinning when there is an advanced grade of keratoconus over here. So it will give us a lot more information for our patients and in our refractive surgery and cataract surgery planning. I don't need to go into this because a lot of you may be aware, but why we are able to do all of this is because of the resolution, which is being on the higher side on the Pentacam OCT, the number of scans it does, and also the scan length. So looking at this, we wanted to look at the repeatability of the 3 devices, the commercially available ones and the newer one, which is on the block. And just to highlight, in a healthy eye, the ICC between all 3 devices of Pentacam OCT, MS39, and Solix, the Pentacam OCT had a better resolution with a better repeatability in terms of 0.89. And interestingly, even in keratoconus patients, when you probably start thinking that the epithelial thickness, the repeatability may not be good, over here also you can see that the ICC of the Pentacam OCT was much better compared to the other 2 devices, which is 0.97. So this just shows that because of the better resolution, you are having a better ICC and the repeatability amongst the other devices. And it's just not for the tear film, it is for the tear film thickness map, the Bowman's thickness map, and the true epithelial thickness map, what you see. So this is what it gives us, and this is for a keratoconus patient, again maintaining the tear film thickness we need to work on, but otherwise the repeatability of Bowman's membrane and the true epithelium thickness map is above 0.96, which is excellent. So yes, this will help us to detect subtle ocular surface changes, understand post-operative epithelial remodeling after cataract or refractive surgery, identify the hidden inflammation, and also help us to plan our treatments in a better process with this software. Looking at biomechanics and Bowman's membrane, we all do a lot of CLEX surgeries. You can see that the topography is absolutely healthy. The refractive error is quite normal, moderate, and you go ahead and do a CLEX procedure. However, on day 1, the first set of patient is quite happy with the quality of vision. The second patient is not so happy with the quality of vision. When you look deeper and when you do the OCT, you can see that the patient who's happy has a good clear interface, but the patient who's unhappy has a little bit of interface edema present, which is shown on the Pentacam OCT. And on digging deeper, you can see that the corneal biomechanics of the patient who was unhappy is a little bit on the borderline side. So it just tells, and this patient may just be, it could help the patient with a little bit of ironing, which would reduce the Bowman's wrinkles, the interface edema, and give a better quality of vision. So OCT and biomechanics can tell us a lot what a topography may not be able to tell us, and integrating all 3 of it could give us a good quality and quantity of vision for our patients, which we always fear when it comes to CLEX procedure. So topography alone may not be useful, but we may need a little more. I have 1.5 minutes. A little bit of new area of work, which Oculus actually probably they encouraged us to do is, you can all see here a patient has undergone a therapeutic penetrating keratoplasty, but again, the patient has come back and the graft has ulcer and edema. So what are we missing? If you see the gram staining, the keloid staining, the patient underwent transplant for ectothelioma keratitis, but and of course after the graft there was a recurrence. So what do you suspect here? Why did it have a recurrence of the keratitis in the graft? Probably the cysts, the trophozoites. At this point of time, you can only evaluate that along with a confocal microscopy. So we wanted to see whether Pentacam OCT can help us identify the cysts or the trophozoites, which could be a factor in recurrence of the disease. And you can see that this is one of the early cases, but you can actually make out how the cysts can be picked up on Pentacam OCT. So whether this is a true picture or not, we went ahead and did a confocal microscopy to confirm. And yes, on confocal microscopy also you can see this cysts. Now, how do we know those were cysts or just an artifact? This is another case who presented with microbial keratitis. Just we did a gram stain to identify what we were dealing with. So it was Pseudomonas. And if you see on an OCT, it doesn't show any cysts. It just shows hyperreflective stromal infiltration and stromal thinning. So what we were seeing on the previous case, which we probably thought could be a cyst, was probably telling us that this is what is the truth. You can also it gives beautiful images when you're dealing with scars also. You can see here, this is a scar patient and there is a traction being formed towards the fibrotic area. And we treated this patient with losartan drops, and post drops, you can see that the traction, which was creating the fibrotic effect, that's being loosened. And of course, the scar is also being area. So it gives you much more information than just the quantification of scar, but how the how the traction is, where it's moving towards. So it gives you a lot more information on this. To summarize, it is a high-resolution, non-contact imaging which provides detailed cross-sectional views of corneal architecture. It truly helps us to see all the layers from tear film to epithelium, to Bowman's layer. You can quantify now the tear film and the Bowman's layer, the stroma, the details in the stroma, the Dua's layer at times, and also the Descemet and Endothelium. So it gives you information of every layer by layer analysis, which can impact our patient care and also help us in enhanced decision making. And with AI, I think it would be a game changer with this new OCT. Thank you.